Good morning, everyone. My name is Olivia Hensey from the New England QIN-QIO, and I'll be moderating today's webinar. Everyone should be muted at the moment. If there is some background noise coming through, and we ask you to please, if you could manually mute your phone, that would be fantastic. And we just want to thank you for joining us for today's IPF Quality Forum. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The presentation was included in the Day of Details email you should have received this morning. You can also find a PowerPoint on our website and click on today's event. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We'll take questions at the end, and I'll provide you instructions on how to unmute your line. We'd like to encourage you to post questions using our chat feature. Please make sure to send your messages to all participants. We're unable to see things that you just send to the host. And at this time, I'd like to introduce today's speakers, Lynn Chase, Kathy Calandra, and Jean Dufresne from the New England QIN-QIO. I'll now pass this over to Lynn to get us started. Lynn.
Great. Thanks, Olivia, and good morning, everybody. This morning, we actually want this to be less of a presentation and more of a discussion. To get started, I am going to share a little bit about the work of the QIO. Then I will hand it over to my colleague, Kathy Calandra, who will talk about the work that we're doing around care transitions. Kathy will share what our goals are, and then we're going to open up the phone lines and encourage you to share what your focus areas are and potentially how we can work together on care transitions. After about 15 minutes, we'll switch gears, and my colleague Jean Dufresne will talk about quality reporting and where there's some potential intersections. Again, we'll open up the phone lines, and we really want to hear from you. We hope that this is an interactive session and that we get to know you a little bit better through this forum. And we're going to do that two ways. One will be through the phone line when we open those up, but the other will be through chat. And to get started, I'd really like to know who's in the room. So if you could use the chat feature to introduce yourself, share your name, your title, your organization, and the state that you're coming in from. Give you just a minute to do that. And as Olivia said, we want to make sure that you're chatting to all participants so we get to know who you are. And please keep that coming. Thanks, everyone. So a little bit of background for those of you who are not familiar with the New England QIN-QIO. The QIO is contracted by CMS in 5-year periods to work on CMS focus areas. There are 14 QIOs throughout the country, and New England is one of them. We have 6 states, all 6 New England states, Maine, New Hampshire, Vermont, Massachusetts, Connecticut, and Rhode Island. The New England QIN-QIO is actually a partnership. The contract was awarded to Health-Centric Advisors, and we have partnered with Qualidine. Health-Centric Advisors has in-state teams in Massachusetts, Maine, and Rhode Island, and Qualidine has teams in Connecticut, New Hampshire, and Vermont. Our current focus areas for the QIO, the scope of work started on August 1st of 2014 and runs through July 31st of 2019. We're working with physician offices and home health agencies on improving cardiac care and reducing healthcare disparities, really aligning our work with the Million Hearts program. We are also working with physician offices and community settings to encourage referral to diabetes self-management education programs for the Everyone with Diabetes Counts program. If that's of interest to you, we offer free DSME evidence-based Stanford programs throughout New England. We're working to raise awareness of the MACRA and upcoming MIPS payment reform for eligible providers throughout New England. and are excited about a new program that's going to be focused on community-based antibiotic stewardship. Again, that's a really broad-based program. We're working in 75% of the nursing homes across the region to improve quality measures. I would be remiss if I didn't point out that one of those quality measures is reduction of antipsychotic utilization. We're also working with a smaller subset of nursing homes to reduce CDI through antibiotic stewardship and also improved communication in those nursing homes. Near and dear to my heart, and we'll explore a little bit more of this, is the Safe Care Transitions Program. We're working with providers and also communities, so grouping providers who want to address opportunities together to improve care coordination and reduce readmissions. And you'll hear more about that work from my colleague, Kathy Calandra. We're also focused on improving medication safety during transitions of care, specifically reducing adverse drug events for high-risk, high-opportunity meds. And those have been defined by CMS in their National Action Plan as anticoagulants, diabetic agents, and opioids. And again, Kath will share a little bit more about that work. And finally, we're charged with providing support on quality reporting and incentive programs in inpatient hospital, outpatient hospital, IPF, and so inpatient psych facilities, and also ambulatory surgical centers. So that's what we are focused on. And our approach to our work is we take our subject matter expertise and also combine that with the providers that we work with who bring their own subject matter expertise and experience. We share tools and resources. We bring providers together. Everything that we do is data-driven. We use both the CMS claims data that we are provided by CMS on a quarterly basis, as well as encouraging and assisting providers with their own data. And then we have events like this where we bring providers together to share best practices, challenges, and that's exactly what we're hoping to do today. Connect those who can help each other. And with that, I'd like to turn it over to my colleague, Kathy Calandra. Kathy?
Thanks, Lynn. So, next slide, please. Our goals established in our contract with CMS aim to improve the care transitions process and ultimately have a positive impact on utilization, as you can see here. It's common knowledge that during the transition of care from one setting to another and at the time of discharge home, there are multiple opportunities for system failure, whether it be because of poor communication between clinicians, a lack of understanding of discharge plans by patients and their caregivers, or confusion over medications. These problems oftentimes lead to readmissions that may have been preventable. We are charged with facilitating interventions across settings that can improve the coordination of care. Medicare also wants to target those patients who are on high-risk meds by increasing surveillance and reducing adverse drug events for patients on the high-risk or high-opportunity meds. For us, CMS aligned this goal with the National Action Plan that noted anticoagulants, diabetic agents, and opioids have been shown to be a leading cause of adverse drug events and, obviously, utilization. We know there are other high-opportunity meds in the behavioral health population, such as antipsychotics. It stands to reason that any and all care coordination interventions and those that target beneficiaries on these high-risk or high-opportunity meds will decrease the overall admission and readmission rates. So finally, the goal is to reduce all hospitalizations. And again, these are our goals set by CMS. All include emergency department, observation stays, admissions and readmissions, and hospitalizations for those Medicare beneficiaries who are on the high-risk meds. Next slide, please. So how do we do this work? Well, We know there is good work already going on within each organization's four walls. But through coalition meetings, we are able to engage our providers by encouraging them to work with us and their colleagues that are in their same settings as well as across settings, such as nursing homes, home health, physician office, and pharmacies. We support root cause analysis using provider supply data or what we have available to us from CMS claims data. This helps us to develop strategies that are not only comprehensive but also feasible. And again, it's not us developing the strategies, we're developing the strategies with our colleagues who are working with each other through these coalition meetings, identifying problems through root cause analysis and putting together an intervention that they believe will improve processes and improve outcomes for patients. Since data collection is paramount to showing the value of any strategy put into place, we help to develop tools that are easy to use while serving to demonstrate the outcomes of the interventions put into place. We want to tell the story so best practices can be spread. The QIN-QIO is in a good position with our analytic support to aggregate monthly data to observe trends and where changes may be needed. Monthly data is usually collected by the providers and submitted quarterly. We facilitate discussions with the key stakeholders involved in the strategy to evaluate progress, and we share these stories with CMS. Each year, we select one intervention that is written up in a Squire report. These are often submitted for publishing as well. But as you can see, it is through connecting and sharing that we spread best practices. Next slide, please. There are multiple quality improvement activities specific to care transitions going on in all of these various settings that you see here. With the patient at the center, everyone is working within their four walls to ensure good outcomes for the patient. In addition to hospitals and nursing homes, home health and physician offices, we know that palliative care has become a valuable player in addressing transitions of care, as has EMS and long-term services and support agencies. In some states, these are called the ASAPs, or Aging Service Access Points, or the AAAs. With the patient in the center, when everyone comes together and works on strategies to improve transitions of care, it's been shown to have great success. Next slide, please. But what's missing? Discussion and best practices have not always included behavioral health providers. This means that that aspect of a patient's care is also being excluded. So we today would like to ask, how can we make behavioral health part of the larger conversation? Next slide, please. So now that you've heard from us, we'd like to hear from you about your efforts and challenges. You can use the chat feature as described earlier, and Olivia in 1 second is also going to remind you how to open your phone line and ask a question. Olivia?
Thanks, Kathy. If you would like to ask a question over the phone line, you can press #6 on your phone to unmute your line. And as she said, you can pose the question in the chat box. Just make sure to send to all participants as you've been doing.
Next slide, please. To get us started, while you're thinking of a question, here's a couple that we thought of to ask you. Does improving care coordination and reducing readmissions align with your own focus? So our goals, I just reviewed with you, how do these line up with your own goals? What are you currently doing in your own organization? Please tell us in chat or call in. And are you working with other providers? And if so, how are you doing that? We have heard in Rhode Island through our discussions with our behavioral health partners that integrating primary care and behavioral health is of great importance, and there's been lots of opportunity to make that system better. Does that sound clear?
Kathy, speaking of Rhode Island, this is Anna Tria Fulton. Can you hear me?
Yes, I can. Hi, Anna. Good morning.
Hi. How are you? So we have our team here. We are at Butler Hospital. I have Charlie Alexander and Diane Block here, and we'd love to share with you just a bit about what we've been doing in this area. So as you know, we formed some internal transitions and readmissions committees, and then over the last year and a half have actually increased to have a larger community coalition similar to what you guys have been doing across the state. So we now have quarterly meetings with all of our related referral sources as well as our discharge sources, so community mental health centers, outpatient providers, as well as our payers, so that the payers can participate in our work. And we've had some really great success in improving care coordination at these meetings, so we can hear from them what their challenges are, and we can share with them what we find to be difficult. And that's been really successful for us in the behavioral health arena. So for those of you who don't know Butler Hospital well, we're a freestanding inpatient psychiatric facility in the state of Rhode Island, and we have multiple catchment areas and work with probably maybe 30 different community mental health centers that refer in and out. So it's been very helpful for us to have this coalition to bring issues to.
Thank you, Anna, for sharing. Does anyone else on your team want to add anything as far as what has been your greatest success or your continuing challenges? Our audience?
Well, this is Charlie Alexander. So I think for us, I could a couple of at least one concrete thing. I think we always have the issue of when we send people out into the community, the providers, frequently will say that, they haven't gotten any information from us, the documentation that we forward never arrives, especially in the community health centers. And I think, actually having people at the table in these meetings, along with our director of medical records, we were able to, sort all that out and actually figure out where the information was going. And then, in fact, the information was arriving. It just was sort of arriving in a central location and not getting out to the various offices, to the community mental health centers around the state. So, I mean, it's little things like that that aggravate people and can really, put us in a bad light, make it look like we're not being cooperative. But, having everybody at the table really helps us resolve these little issues before they blow up into big things.
And this is Diane Block. I would add just one other. I guess I can't say this is something that's working perfectly, but I just want to raise it as something we continue to need to try to find some better community partners around. And I know that in your slides you had asked or raised the issue around opioid addiction. And for our folks that have very high readmission rates who are Medicare members here at the hospital, often one of the biggest problems is stable housing. And so we have people who come back to the hospital, if they're Medicare only particularly. We don't have any residential programs except the Salvation Army, which they can go to. And the Salvation Army is a very unique program. Some people are able to get through that program well. Some people don't do particularly well. It's kind of work-oriented. So we've got people who are quite disabled. It's often not a good fit. But for us, I think this is one area that we need to continue to expand is how to address, and I'm sure this is true in other states, how to address the issue of helping people get into stable housing when they're disabled, have multiple co-occurring disorders, and not wind up back in the hospital because they've just gotten into a crisis. So for our folks who have a Medicaid secondary, that's easier because there are programs in our state residential treatment programs that do take Medicaid. But for folks who are Medicare only, we don't have that resource, and they often do not have enough money to come up with co-pays for psychiatric medications, never mind stable housing. It's a real problem that does influence our readmission rate to our addictions inpatient floor.
Thank you. I'm sure others share the same challenges. Are there others who have the same challenges or similar, or have found a way to, in your state, to tackle some of these problems? And we want to land where our last question to you is going to be how we can best support you. So we're open to your suggestions and recommendations as well. So if you need to open your phone line, remember to press #6, or you can use the chat feature to ask a question or give us your response.
This is Lynn Pace from the New England QIN-QIO, and I know a few years ago when we were exploring transitions of care for Medicaid projects, one of the areas that became obvious that it was a challenge was patients who had both physical but also behavioral health conditions, and the connection, the information transfer between those providers. And I would love to hear from others if that is a concern that you're facing, or if there's a way that you've worked around it. You can use the chat feature to share, and I'd like to hear from all of you. If you've overcome it, great, let us know. If you are working on it and would like to explore that, please let us know. Or if you want to open up your phone line, all you have to do is press #6. Are you getting the information you need from other providers?
Hi, this is Pat from Acadia Hospital up in Bangor, Maine, and we have more trouble getting our information to the correct provider, next care provider, once they leave our hospital. I was wondering if anybody had anything they could share about that.
Thanks, Pat. That's on getting information to the next care provider. Identifying who and how. Has anybody been working on that or also struggling? #6 to open up your phone line.
I'm wondering, Pat, this is Kathy Calander, if you're referring to both medical and behavioral health outpatient providers follow-up?
Yes, both. Primarily the one, though, that's dealing with the psychiatric medications, because that's the one we measure for the IPF QR. We have to transition that information within 24 hours of discharge, and sometimes we don't know, the patient doesn't provide us with the correct information, or the other challenge we've had is they provide a name, but then that provider communicates with us that they're not, that's not their patient.
This is Diane from Butler. Our social services department here, over the years, I don't know, I think we've just worked really hard. We used to just, in the social work department, have meetings with liaisons from all our community mental health centers. Because we refer to a lot of the same psychiatric providers, I guess, we have a very rich referral network. So what we've done to try to make the process work as efficiently as possible is to have the patients, sign releases of information as soon as possible, and immediately the social workers work on scheduling aftercare. That really starts happening, from day one. And then we've arranged a system with our medical records department where once the discharge information is entered in the record, the medical records department can just fax out the aftercare information to the providers. So I guess it's sort of two steps if you're saying you don't have a good referral network and you're not kind of finding out in time to research other options. Or I know for us around the timeliness, we would get complaints that providers weren't getting information before they actually saw the patient. So we managed after a couple of failed strategies to have this process where the physical release of information does not need to reach the medical records department before the information can be sent. The assumption is made if the appointment is put in the electronic record, there is a release in place, so medical records just faxes that immediately. So that's been helpful to us, and I don't hear as frequently of providers complaining they're not getting information. So we do try to get that out certainly within 24 hours of discharge.
24 hours is the new requirement for the new measure. And so it's a little quicker than the 5 days. So we've had to do a little retooling in front of the medical records as well, just to make sure we have coverage, 7 days a week to make sure the stuff gets out. So we're not there yet, but we're close to that. We're up in the, high 80% of our stuff is now getting out within 24 hours. So, but that's been a bit of a struggle.
Thank you. That's helpful.
And again, thanks to our team at Butler. I see that Ann Jennings has also responded in chat. She's saying that we have been working on our faxing program for next level providers. You've set up a fax back program to determine that the information was received, and that you are saying has decreased the frequency of next level care providers complaining that they have not received any discharge information. So thank you, Ann, for sharing. Does anyone have a question for Ann? And if you don't mind, I would like to ask, you said you set up a fax back program to determine the information was received. That's really key, because that is what we have found as well, even on the medical side. The hospitals score very high on getting their fax documents, discharge information out. But when we looked at the other end, the documents were not necessarily found in the office setting. So wondering how you are validating that the information was received, if you can share that.
Can you hear me now?
Yes.
Okay, sorry, I had trouble with my phone. On the fax sheet itself, there's some instructions to the people receiving them. And when we initiated this program, we started with the providers that are within our network of the hospital and got that working, and then went out to our local agencies that we deal with all the time and explained to them what we were trying to accomplish. And what they do is when they get the fax, they take that fax sheet that we had sent, the cover sheet, and document their name or whatever, their date, and fax it back to us in order to say, yes, we received it. And within the hospital network, we've also then been working with the practices to, what do you do with that once you get it faxed into the office? How do you get it to the PCP who is going to be seeing that patient in a week. And so those are all issues they're still working on the outside of the hospital. But we have since been hearing that because we were doing this, people were actually getting the information, and it was within their system that sometimes they weren't getting it timely within their office. But that's a continuing process.
Hi, I have a question. This is Maureen from Health Centric. Are you making all of the appointments for your patients?
That's the goal. The social workers and the nurse. We have a nurse practitioner on the unit who deals with all of the medical issues and for the patients up there. And they do the follow-up with the PCP and make those appointments with the patient, and the social workers do the other follow-up for any other referrals they have, whether it's for counseling, psychiatrists, referrals to outside agencies, that type of thing, yes. We try to do it at the time so they have those appointments before they actually leave.
That's great, because this is our goal is to integrate all of this so that the PCP knows what's going on as well as the psychiatric team.
Right.
Thank you, Ann.
Sure.
We've got about 4 more minutes before we transition over into quality reporting, but would love to hear again any focus that you have currently on transitions of care, what your biggest concern or challenges or any successes that you've had. I would also like to know if you're currently working with the QIO. And for those of you who don't want to jump in on the phone line, that's fine. You can weigh in via chat. If you could just send a chat to all participants, that would be great. Or we'd love to hear from you. #6 to open up your line.
Hi, this is Maureen again from Rhode Island. One of the things that we here at Health Centric as the QIO have started to do in some of our other work in care transitions is set up coalitions. And I know many of you out there may already know about these or maybe have not started to participate, but we had brought the hospital, the nursing home, the home health together originally, and now we have started to branch out to invite anyone that wants to come from our mental health centers, from our psychiatric units, and we're starting, and including the payers that work with the psychiatric patients as well. And we seem to be getting a lot more of their presentation at our meetings, and it really, we had one last night, and the payer there from our Medicaid was talking about work that they're doing that we were totally unaware of, and the people at the meeting were like, oh my God, I can call you, and she said, absolutely, and they can set up more services that, maybe weren't available, especially was our most southern part of the state where they don't want to go beyond the bridge and travel, and so that now they're starting to have more stuff down at that end of the state. I don't know if that's working in other states or not. Maybe you could share if you are doing anything like that.
Thanks, Maureen. So we have probably about a minute or two. We'll ask one more time if there are other ways that you can think of that we can best support you will see at the end we will put up contact information for you to get more information. But food for thought, we've tried to give you some examples of what's going on in similar situations and how people are addressing it. And we really can't say enough about the collaboration piece of it and how making those connections helps to spread best practices and helps people to strategize how they can make things go smoother for them and obviously the patient. I do see some. Yes, Lynn, are you going to see the comment from?
Yeah, I was just going to say thanks to Pat for sharing. that when she was at the medical hospital, they interacted monthly around the QIO, around measures and strategies. And that's what we're hoping to get from this group is there value in bringing together a group of inpatient psych facilities, units, and freestanding to talk about that. Is that of interest or value? And if it is, we're happy to do it. And if it isn't, that's fine too. Pat, I didn't catch which state and organization you're from. We'll make sure that we reach back out to you.
So if there are no more questions, I believe we can pass the ball on to our colleague, Jean Dufresne, who will talk to us about the quality measures. Next slide, please.
Thank you, Kathy. Thank you, Lynn. Good morning, everyone. It's Jean Dufresne. All things reporting, all things Federal Register. Next slide, please. And just to start off, wanted to let everyone know that the QIO is here to offer assistance and resources around your inpatient psych measures and reporting, and making sure that those measures not only are reported on time, but if there's any need for performance improvement, that you realize we are here to work with you on those measures. These are your recent measures for fiscal year 17, I believe reporting just completed. Next slide, please. And if folks, we had the NHSN, I know inpatient psych facilities just began their reporting last flu season, and we had quite a bit of calls and were able to provide technical assistance to IPFs that we're having some struggles getting the information through the CDC's NHSN website simply because there was a box that had to be checked off. But we were successful in not only helping folks get that done, but CMS also allowing a bit of an extension on the deadline. So there are some things we can assist with, and usually if you have a lot of the same providers struggling, CMS is very open to, allowing a little bit of an extension. And we like to think we're the kind of the go-between CMS and you folks. Next slide, please. I'm also looking at and keeping up with measures that are currently being reported. And like you, I attend web events and am soaking in and learning all of this. Just to remind you again that we are a resource. If you haven't, if you didn't know that, or you were unaware of that, that certainly if you need help with your measure reporting, or if you need help just simply navigating a QNet report, pick up the phone, shoot an email over to us. I have helped IPFs walk through the non-measure reporting measure, if that makes sense. It probably does to the IPF folks, and other measures that people are struggling with. And with all of this transition records, the transmission of the transition record, and that sort of thing is all tying right back into your care transitions work. So I believe the measure reporting is very, very important with regard to that. Next slide, please. And it wouldn't be complete if I couldn't tell providers what's coming. So for fiscal year 19, CMS is going to begin the 30-day all-cause unplanned readmission following psychiatric hospitalization. And I just want to point out to providers that since you are still in pay-for-reporting mode, that your performance in readmissions is not going to be affected, meaning you're not going to be subject to any type of payment determination. As long as things are reported, you earn your APU. And the 30-day unplanned readmission will be a claims-based, much like the inpatient quality reporting, and CMS will provide you with your hospital-specific reports, I believe, in 17. And that's something else we could always, if this group wanted to, we could get back together and take a look at those reports and take a walk through some of that methodology and what that looks like. And the other that's up and coming is the alcohol and other drug use disorder treatment provided or offered at discharge and a subset to that. Next slide, please. And I also wanted to point out, even more down the road, is CMS is considering moving IPF to electronic clinical quality measures. Something that if you do any work on the inpatient quality reporting side, if not, that is definitely something that QIN-QIO can provide education around, resources and support, whether it's a phone call, a webinar, an on-site visit. They're looking also at the use of psychiatric scales and instruments and developing and adopting additional measures, for individuals with substance use disorders, such as the hospital-based inpatient psychiatric services, or HPIPS-1, and a patient and caregiver perception of care measure focused on the psychiatric patient population. Take that to mean like a survey. Next slide, please. And I'd really love to hear from everybody. Unfortunately, I can't dive into measures as far as, the abstraction piece today. But if it's something that folks are interested in, we could certainly talk about how to move forward with this, how does this all tie into care transitions, getting people together, whether it's in a quarterly fashion, and just reminding people again, we are here for technical assistance and support. We are here for performance improvement projects. We can take a look at all of your data, see where you need some help. So with that, I'm going to open it up to questions. And Lori, I do see your question with the population for sub-3 be determined solely by ICD-10 coding. Those are the sorts of questions I can't dive too deep into today, but certainly something that I would like to, if this group is interested in, pull you all back for those sorts of questions and Q&A and discussion. Is there anybody with any ideas on the phone as to how they'd like to move forward with the quality reporting and using the QIN-QIO? Or you can chat it in. Okay, future training. I'm sorry, Larry, I didn't read the whole question. And we can certainly look at if people would like educational, more training, more educational learning, let me know. You can chat it. You can unmute your phone, #6. What do folks think? What do they want to do? Yes. Okay. Thank you, Christine. Future training and calls. Okay. And it would be good, too, if folks could, either, get on the phone or in the chat and let me know what you want that future training to look like. Yes, Pat, we can send you contact info for the IPF QRS questions. Absolutely. And if you're not currently on or not receiving emails from me on a weekly or every other week basis with updates, my contact information is on the last slide. Shoot me a quick email and I'll add you to our listserv. But what I was asking folks is if we were to do a future training around measures, what would that look like? What are the biggest challenges around the inpatient psychiatric measures that you're having? Okay, I don't think we have any questions, Lynn.
Thanks, Jane. We are happy to give you 15 minutes back in your day, but also want to make sure that this event and this discussion is helpful for you. I know people had questions about Jean's contact information. Jean is our resident quality measure guru. She knows the details, and she's the only person I know who actually reads the Federal Registry. So is quite up on those things and serves as a good resource. So I have included her email address in chat, and it's also on the slides that were shared this morning and are posted on our website.
If we could advance the slide, Olivia. And one more.
Great. Thanks, Jean. So I wanted just to highlight again that in each state, the QIOs are focused on things that I think probably align with your interest and focus areas, both the care transitions work, working with providers individually on efforts to improve care coordination, or connecting you with others in your community to better address those gaps. We are also working on the quality metrics, and there's potentially a partnership opportunity with some nursing homes to reduce inappropriate antipsychotic utilization or to address medication safety. And it sounds like, from what we heard from Butler, that there's a focus on opiates in your care setting as well. So we'd love to hear from you either on this event or following the event as to how we can best support you. And that's one-on-one or in a group setting like this. This slide does include the state team key contacts. In Connecticut, that's Carol B. In Maine, that's Amanda Gagnon. I believe Amanda is on the line. Massachusetts, that's Dawn Hobel. New Hampshire, that's Margaret Crowley, and then Margaret Vaughn. In Rhode Island, that's Maureen Marcella, and you heard from her today. And in Vermont, that's Reggie Cooper, and Reggie is also on the line. And with any detailed specific questions around quality reporting, training needs, just the update, that is Jean Dufresne, and her email is on the slide as well as in chat. I want to thank you all for your participation in today's event. Olivia, could you provide an update about when we close the session?
Sure, no problem. Thanks, Lynn. Thanks, everyone, for a great discussion. I just have a few last-minute announcements before we end the call today. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email with a link to the evaluation. So if you could fill it out then, we would appreciate it as well. As mentioned at the beginning of this webinar, the PowerPoint will be posted on our website, and within the next few business days, we'll also post a recording and a transcript. And I think that's about it. Thanks, Lynn, and thanks, everybody, for joining us.
Thank you.
Thank you all.